Okay, everybody, welcome to Journal Club. It is June 19th, 2019. We are here in South Jersey at Wall Township. Remember to like us on Facebook so everybody could be aware we're broadcasting live. The more places I travel around to, the more people stop me and say, we watch you guys every week on Journal Club, which is great. We're happy to hear that. I think many weeks we get like 7,000 people. So this is really good for us. Remember, you can find these videos on our website, www.emsfellowship.com, or you can go to our Physician Response Program website, www.md1program.org. So we are in the midst of interview season here for EMS Disaster Medicine Fellowship. Even though most places haven't started, we start really early because we are the largest EMS fellowship in the world. So let's get started, and we'll see what kind of questions come up. We're going to do a little shorter journal club than usual, just because so many things are going on. And tonight, if anybody's interested, I'm in Queens, giving an EMS lecture at 7 o'clock. I forget what the address is, but somewhere in Queens, which will not be live. But I'm sure there'll be a tremendous food there, none of which I will eat. So, okay, guys, so interesting cases this week?
I have one, actually. So I was working in the ER, but it was actually a case that was started in the field. It was a STEMI notification. So I got advised by the charge nurse we had a STEMI coming in, and as an ER doctor, usually these are great cases for us to take, right? It was a very busy night, and we're always excited for them to come in because we get them in, we get to the cath lab, and we're done. But that was not like this case at all. So he comes into me, and the first thing that I noticed is this is a gentleman who's kind of young, in his 50s. The EMS notified us that there was an anterior lateral wall MI, and the patient had just had a stent placed only 10 days ago. Hadn't filled his scripts for any of his medication as an outpatient. We see this all the time. It happens. So they roll him in to the door, and he's gray. He has no color, and he's vomiting everywhere. It was like The Exorcist. I felt really bad for the patient that was on the other side of the curtain as this guy was rolling in. But, we were able to deal with that. So we pull him into the room, and the first thing that I noticed is right before he started vomiting is he was being bagged. So as we know, this is one of the, because he had stopped breathing just as he was rolling in the door. So he actually was not breathing. He was in respiratory arrest when he came in. Initially, so it seems like they had bagged him a few times. I saw them rolling him down the door, bagging him, and then he just kind of sat up and vomited everywhere. Okay. So they were using the bag of death, as we call it. Yeah. So the first thing, they also advised that, which was not given in the report initially, that because it happened as he rolled in, he went into VTAC and he needed to be defibrillated. So he had been defibrillated with 360 joules prior to me getting him. He's on monitor pads. We roll him in, still vomiting. So obviously we need to get an airway. But the guy was now awake and alert despite his recent arrest. And he said that thing that we all hate, that when people say, he said, am I dying? And you know that whenever anyone says that, the answer is, yes, you probably are right now. You never tell someone that. So you say, we're going to try to make that not happen. We're going to try to do everything we can so that you don't die. And that's, what we told him. And then I had to make a decision at that point of how I'm going to take this guy's airway, because I couldn't have him continuing to vomit and going in and out of cardiac arrest. So I decided to perform an awake intubation with ketamine. I gave him... So like a DSI? Exactly, a DSI. I gave him 200 milligrams. Used a glide scope because that was available to me at the time, and he was a very large gentleman with a big body habitus and a short neck, so I thought the glide was my best shot and was able to get the airway. And he woke up after we got the tube in, but he was awake and alert following commands, and then he went again into a VTAC arrest. So we started CPR. Cath lab had been activated. They're on their way there, and we decided to defibrillate him. We got him back. And the cool thing about this case is every single time we would defibrillate him or start to do compressions, he would be completely awake and alert. He would open his eyes, squeeze my hand, blink his eyes. He was in pain, so we gave him some fentanyl, which I always think is more important than sedation after you put a piece of plastic down someone's throat. So he responded well to that, stayed awake and alert, and he had already gotten amiodarone in the field, 150 and 300. So at this point, I decided to give him some lidocaine. So I gave him 100 milligrams of lidocaine, and it resolved everything for a little bit. And we're going back and forth, but at one point, the second time after he went back into cardiac arrest, and now he'd gotten 2 lidocaine, he already gotten the amio, some epi, we decided that we would try double sequence defibrillation. So we, in 2 different rounds of compressions, after the first round, we put 1 set of pads on his chest, continued compressions, no one stopped. And then on the second round, we rolled him, slapped it on his back, put it back down, and we double sequenced him at 720, and that was the best sustained ROS that we had. So
That's great. So
It was fantastic.
for all the naysayers about double sequence defibrillation, one, it's we wrote the second paper ever about it, and we have lots of people who are walking around now who would have been pronounced dead because they got double sequence defibrillation. So it's part of what we do pre-hospitally, somewhat regularly. So that's pretty cool. So did you ever do a bedside ultrasound?
We did have some decreased pump function. With the recent MI and now this MI, we expected that. So we actually were able to get him up to the cath lab. And I think the coolest thing that happened is he was so awake and alert, but intubated. And we had also given him we also gave him during the code some calcium as well. And we think that might have helped.
Yeah.
He actually, some of the cardiologists, when you bring someone to the cath lab who's been coded, some cardiologists won't even bother coming in. You say the word cardiac arrest, and they're like, well, don't pull me out of bed at 2 o'clock in the morning for someone I might not get to take. But as he rolled into the ER, I said, give this guy, I told the patient, I said, sir, can you do me a favor and give the cardiologist a thumbs up? And he actually gave the cardiologist a thumbs up while he was intubated.
Yeah.
So,
Because obviously he's looking for neurologic function.
Yeah.
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 I appreciate that. So, we'll play Monday morning quarterback. So, amiodarone has no benefit in cardiac arrest, right? There's arrest in the live trial, and there's a third one that came out in the last year or so to show, ALPS, to show no benefit of amiodarone over nothing in VFib cardiac arrest. And the arrest in the live trial, both pre-hospital studies, which demonstrate the same thing. So all these antiarrhythmics are poisons. That's what we call them, because there's no benefit to any of them. Yet that's what we do in cardiac arrest all the time, with no outcomes benefit. So much of what we do is just completely made up. Now there was the big study, which was put out like 3 years ago, about kids in VFib arrest, which is a rare phenomenon. So it took many years, only one study in the literature, to show better outcome with lidocaine. Right. So we know in kids the right answer is always lidocaine over amiodarone, because that did have better outcome. And probably it's the same thing with adults, but we just don't know. There's never been a prospective randomized trial of people getting, of lidocaine winning, I should say, lidocaine winning. So, you can give a poison, sure, it sounds good, particularly somebody who was in VFib arrest, right? But, I think double sequence probably did it, right?
I think so. He did go into VFib at certain points, so the question is, after we double sequence him, it was like, the question was, should we give him something else to try to prevent this irritation? And I think at the end of the day, we all knew the only answer was for him to get that stent opened up again.
Yeah, right. I think so too.
Which is what it was.
And they can sit around checking his K and his mag, but who really cares, right? They can, whatever the results come back.
And he has more?
And he has Malone.
That's a good idea, actually.
Yeah, what a mess this is. So I get asked about this over and over. I'll probably be asked tonight, and that was Joe Ornato's study, right, out of UVA, right, or MCV, where the only drug that shows outcome difference is a drug none of us give, which is esmolol. So we've all been taught not to give beta blockade to people who are having STEMIs, Because remember, we all used to give like IV low pressure. You guys remember this? Up until 2005, we all gave IV low pressure to everybody who was having a STEMI. We gave 5 milligrams IV Q 5 minutes times 3. It was like the standard. Then the study came out to say that too many people go into cardiogenic shock, just stop it, even if the patient's tachycardic. We're talking about this in MAB today too. And we know tachycardia is a terrible sign if somebody's having a STEMI in terms of outcome. So we all stopped doing that, and then we all like say over and over, we don't resuscitate people on drips, right, when they're critically ill. So they do a study to prove both those things wrong, to say an esmolol drip has better outcomes for people who are in cardiac arrest. But it was only like 20 patients. It was a small study, yet nothing else is proven to help, except for lidocaine in children who are in VFib arrest, which is a rare phenomenon, mostly in the post-cardiac kids and cardiac surgery kids. So I don't know. People always talk about this, and then we have docs on the console periodically give like IV metoprolol to people, and the paramedics are confused about if this is the right thing to do. I don't know. It's I don't know. I mean, what people say, why don't we just do it? And I think the answer is, what if we do a study tomorrow which shows we've harmed all these people, right? So it sounds kind of interesting, but we all always say you don't resuscitate. You don't give we are anti. If you don't know us by now, we are anti-nitro drips, right, for acute decompensated heart failure. It makes no sense. We give nitro boluses, right, over and over again. I don't know. What do you think, Pat?
And I've had one case of resistant VFib that I remember we said, okay, nothing else is working, let's try esmolol. We had less VFib, but the outcome was still the same.
Yeah, and you did double sequence?
Yeah.
Yeah. And most people would have done double sequence. I guess if you had a persistent VF, if you have persistent VF, you could have considered doing VA ECMO,
Yeah.
right? If you were in the right place.
Especially with the patient where their neurologic function, so we know the problem is the heart. We take that out of the equation until we can figure out what's going on with the heart and get them to a cath lab or something.
Because he was a young guy, right?
Yeah.
Yeah, he was in early 50s.
I mean, one of the things that when we look at like this literature, which is very, really sparse to begin with for like esmolol, the biggest thing is that you think of like they tend to equate VFib to like the electrical storm of the heart. It's almost like a seizure of the heart. I mean, brain, so it's a seizure of the heart essentially. And what they're saying is overexcitation, and so if we have overexcitation, why are we giving an epi to like something that's overexcited, right? So
10 milligrams of epi too.
Right. So I mean, the question is that if you do kind of decide to go down this protocol of like giving an esmolol drip, the ideal way or the appropriate way to probably do this is in a setting of where you have a patient in VFib arrest where you haven't given any epinephrine at all. And so if you haven't given any epinephrine to a patient and now you're actually someone in VFib arrest, you can potentially give them an esmolol drip and then see if you can probably convert them from that perspective. But the moment you start giving someone epi, and now you're trying to like kind of reverse that effect, like the beta blocker, you kind of defeat the purpose in a sense. So the thought process is that by and large what we want to do is if we can approach these patients early on when they've had VFib arrest and no epi, that's the ideal candidate. Now, pre-hospitally, it's usually going to be a patient who was seen by BLS that got shocked by an AED, and now you arrive on scene, this patient's like VFib. Otherwise, what ends up happening is that most of our medics will usually give epi beforehand, and we kind of lose that opportunity to give that esmolol drip. The other thing is like when we talk about low pressure is that low pressure. One of the problems with low pressure is that the half-life is much longer than esmolol. So when we talk about most of these patients when we get ROSC, we're kind of chasing our tail sometimes with their pressure on the back end. Right, so with esmolol, at least we can titrate it and we can turn it off, and then that way, if they do bottom out or they're in some cardiogenic shock, we can actually kind of challenge that on the back end.
What you're saying is so important, because the bottom line is we have no idea what we're doing in cardiac arrest still in 2019.
Right.
We bag people, we know that's bad. We interrupt compressions, we know that's bad. We do mechanical devices, and we know there's no good outcomes data on that, right, except to say there's no difference. Boy, what are we doing that helps people? A little bit of double sequence fibrillation, although that literature's gone back and forth. But like you're saying, this is Joe Ornato's argument that what other tachydysrhythmia do we give a sympathomedican, except for VF and pulses VT? And the catecholamine levels are already so high. Why do you need more catecholamines? It makes no sense.
Right.
This is the benefit of potential beta blockade, and that's just why maybe the esmolol helps, although I hate the idea of giving like a drip of somebody in cardiac arrest. It goes against everything
Sure.
that I know that makes sense. So, I mean, and we have recent data, right, which say epinephrine is not associated with better outcome, right? And before that, we had 40 years of data which said, the summary of epi is you get more ROSC and nobody walks out of the hospital more alive, right? So we waste our time in cardiac arrest giving epi and giving antiarrhythmics without any outcomes benefit, right? And then we over-aggressively bag, and that's associated with decreased blood flow to the heart, and shunting and decreased oxygenation. So what are we doing to help these people? And I guess the answer is always the same thing: just get there fast and hope somebody in some public place grabs an AED and shocks them, and they convert quickly.
Yeah, those are the things that make the difference. So.
Good CPR, uninterrupted CPR.
Right. Right, and the
Getting
biggest
this
study, and
patient
the
to the
best,
cath lab.
well, the best study came out in 2015 in JAMA to say actually good CPR is associated with benefit. Before 2015, we didn't have any really big good study, and but good uninterrupted compressions. The only number I tell people to remember is that every 5 seconds you interrupt compression, survival goes down by 17%. Right, I always repeat this. For every 5 seconds you interrupt, there's a big circulation article. For every 5 seconds you interrupt compressions, survival goes down by 17%. So when somebody says hold compressions while I intubate, that goes against every freaking piece of science known to man. Although people do this all the time, because the idea about cardiac arrest is not to freaking intubate. Peter Safford's been saying this since the 50s. Circulation, airway breathing, not airway breathing, circulation, right? Focus on forward flow. We focus on the airway because it's sexy, right? But it's a big mistake, and we all do this, right? So when a paramedic brings the patient in, and all they have is a supraglottic airway in, don't try and intubate the patient. Leave it alone till you get back ROSC. And then go ahead and try and intubate the patient. Who cares about the airway in this scenario, right, in cardiac arrest? I don't know. It's still like, so do not interrupt compressions, do not interrupt compressions, do not interrupt compressions. This is why we stay and play in cardiac arrest. We don't load and go. Running to the hospital worsens outcome. Staying on scene improves outcome. And we all see this over and over. Every time you bring somebody to the hospital, your entire CO2 goes down and you have worse outcome. Right? So we stay on the scene. The whole caveat to this, which is confusing the heck out of me, is that some centers have VA ECMO. So if you have a persistent VF patient and you're in a hospital that has VA ECMO, which you can do in the ER, which anybody can cannulate, right? Then maybe there are some people who are young in the right setting where you want to bring them to the hospital and risk the end-tidal CO2 going down for the potential benefit of VA ECMO. But man, you better be in a system that has that VA ECMO available, and you better be choosing the right patient, right? Because you're decreasing the odds just by transporting the patient. Because we all do terrible CPR in the back of moving ambulances. Isn't this confusing, you guys?
Very much so.
Yeah, I mean, you have to know for certain that there is a reversible cause that you're going to be able to bridge with ECMO to treat. And sometimes you have that information, sometimes you don't.
Right, and you have to know that your center capable of VA ECMO.
Yep.
And most places are not. But people have been for decades. I mean, Penn State's Hershey's has something like on the wall. You hit the button, and somebody comes and does VA ECMO on your patient if the ER doc's not capable of cannulating. But again, you want me to cannulate a patient on VA ECMO? Give me somebody who's 50 years old in VFib cardiac arrest. You bring a 90-year-old with 5 comorbidities who has metastatic CA. You're bringing the wrong patient to me.
Yep.
Right? Yep. And everybody talks about, Paris and, doing out of hospital VA ECMO at the famous picture at the train station. Right, we're talking about doing this too. The problem is the cardio help, you buy 2 of them, is $500,000 for very few people who will benefit. Is it worth it to do it out of the hospital? Or do you move somebody and risk them dying just because you're doing inadequate compressions when you're moving them? These are difficult answers.
So Will Thumbing poses a question on Facebook asking, what if you're 5 minutes from an ER with a cath lab? Do you stay and play, or do you transport that patient?
Right. I mean, I think it's so. I assume the question he's asking is for the patient who has persistent VF, right?
Yeah, I think so.
Persistent VF. Well, you have to know your system because many places won't take you to the cath lab in cardiac arrest, although some will. Most still around the world will not, right? And, a cath lab is not, there was just a study that people, like a year or two ago, which showed actually, because we all talk about first medical contact to vessel open. There was a study which actually looked at people in cardiogenic shock, and they did better when they got like Impella devices and then went to the cath lab. Although you get your Impella in the cath lab, but you actually delayed getting that vessel open for Impella for somebody in cardiogenic shock. So, and they had better outcomes. So I think that, listen, if you have a STEMI, you're always better to get the vessel open. When somebody says, should I heparinize, should I give nitro, these are all just silly questions, right?
These are things in the
Get the
meantime.
vessel open, right? It's all about getting the vessel open. None of these other made-up drugs are on the same level as getting the vessel open. If you're in VFib cardiac arrest, you got to know where you're going. If you're going to a community hospital, you're probably not going to get somebody to take somebody to the cath lab who's in cardiac arrest, right?
The other part is the time of day also.
Yeah, there's
Because
nobody.
if there's nobody in-house to do it, and they have to be called in.
Almost overwhelmingly throughout the United States, nobody's staying in the cath lab.
This was at 2 a.m., of course, by the way, just to
Yeah.
give you some context, because of course it was.
Right. Even during the day, during the day, how quickly can you get into a cath lab? It depends what hospital you show up at.
Some places only have one cath lab, so if there's a patient already on the table, you can't like pull out the cath that you're doing right now.
A friend of mine who's an interventional cardiologist always says to me, because I take cath call 300 days a year. You want me to come in now for people who are in cardiac arrest with ROSC but no STEMI? When do I get to go home? And I appreciate that. But, if you are in a big teaching institution and you want to take people with cardiac arrest without STEMI on the EKG, that kind of makes sense. Does that answer his question?
Maybe.
I think it's a hard question.
But also, if you're in a cardiac
Please.
arrest, isn't that like a failed stress, basically? They failed their stress test. They went into cardiac arrest. They should get cath. Even
Well,
if
of
it's-
course they need to go to the cath lab.
Yeah. It just matters when. Can you do it urgently, like the next day? Can you
If
do
they
it-
don't have a STEMI.
I mean, there's a great article that was published in in the cardiology literature that talked about these patients who didn't have a STEMI on the EKG with ROSC and what are the parameters of taking these patients to the cath lab. And you literally what you're looking for is you're looking at, some of the hallmark things that we talk about. So like, downtime, witness arrest, and, early defibrillation and the initial rhythm and stuff. But then, more so predominantly they're looking at like the EF, they're looking at the heart, what is it doing?
Yeah.
They're looking at the lactic acid, they're looking at,
So every
the
ER
pH.
doc should have an expertise in doing
Right.
bedside echo.
Exactly,
period.
100%.
Wall motion abnormality, how thick is the wall?
Yep.
The ER doc looks at it.
Yeah.
Right, and gets an idea, what's going on.
Right, and that's key. So being able to kind of have an intelligent discussion with a patient with ROSC who was in VFib arrest and what you're seeing in front of you is crucial. And being able to tell whether or not, a certain patient may or may not have a poor outcome is a shared decision-making that you have to have with a cardiologist. Now, most people will say most of these patients will end up getting an urgent cath, so within 72 hours. And that's what most of the cardiology people kind of talk about.
Well, again, specifically, you're talking about somebody who has cardiac arrest outside the hospital.
Right.
And then we do a 12-lead EKG in the ER or pre-hospital, and there's no STEMI on the
No
EKG.
STEMI on the EKG.
What do you do with those patients? Should they still go to the
Exactly.
cath lab? And prior to this recent study in New England Journal of Medicine, my answer was absolutely, because there was one study which looked at 8 papers. It was 7 of the 8 were a meta-analysis, but 1 was a prospective trial. And they had better outcomes when they went right to the cath lab, before this recent New England Journal of Medicine article. And what percent of people have a culprit lesion? And the answer was 35%.
Right.
35% of a culprit lesion if there's no STEMI on the EKG. And this recent article came out that everybody's talking about, which shows no better outcome, right? And it was in a good journal with good statistics. And now, again, it's all a freaking
Money
mess.
in the waters.
Yeah.
I know that some of our colleagues, I forget where, I want to say Kentucky, they're doing this, they're looking at this problem right now. They're taking all comers, cardiac arrest, putting them on a mechanical device, and then taking them to the cath lab.
Yeah, I mean, it's easy for us to say this because we're not the people driving in at 3 in the morning, for somebody who doesn't have a STEMI on their EKG. And again, most places around the world do not keep interventional cardiologists in-house 24/7. And they don't keep them in-house during the day in their practices. And if they come down to the ER, they happen to just be rounding on patients. And you just got lucky that on Tuesday, the guy rounding was interventional guy, but on Wednesday, it was non-invasive guy. So you had your STEMI on a Tuesday. And this is all the stuff patients don't know, right?
Oh, I mean, it's also stuff that doctors don't know. So how are the patients going to?
Right. Because some places have like a cath lab on call, and some places, it's interesting how this works out politically, and we don't like to have political discussions too much here. But if you're in an inner city hospital and you do not have a doctor, you default to the guy who's covering interventional cardiology. Bam, and you can go right to the cath lab. if you happen to have a doctor and live in a more suburban area where a lot of people have cardiologists, then the ER may have to call your cardiologist first to find out who they want for interventional, then that patient takes you, and then you go to the cath lab with that person, and now some time has gone by. So hospitals where all the doctors agree to to give up their patients for the stent, right, then potentially have better care than the people who have private doctors, right? That makes no sense, right?
And the other issue with the cath lab is in our standards and morbidity statistics and everything, these are very high-risk patients, and then when they don't have a good outcome, it gets kind of charged against them as a
Bad.
bad outcome,
Yeah.
when really their odds going in were so low anyway. And a lot of people are reticent to bring people to the lab without clear evidence of possible benefit.
Right.
Because of that, because they don't want another black mark against them.
Right. I mean, there are many centers around the world which have a higher mortality, but you got to look into that. It's not just about a number being published in the paper. Are they taking higher risk patients
Exactly.
consistently, and did they get better at that? So they have a high and what happens to those people? They get sued more. So just because you're getting sued more doesn't mean you're a bad doctor. It may be that you're taking higher risk patients, right? But how do you explain this to the public?
Yeah.
All right.
Yeah,
Oh,
so
soapbox.
this guy, just to follow up, this guy actually, he did have re-stenosed his stent. He got another stent and opened it up. He got a
10 days
balloon.
later, he re-stenosed his stent, right?
Yeah.
He wasn't taking any.
But he
He
wasn't
wasn't
taking his
any of
meds.
They put in a balloon pump because he had a little bit of failure, and he was extubated a couple of days later. Balloon pump was removed. A week alert and oriented. Doing great.
So balloon pump, I mean, just as another soapbox, balloon pump is not the answer to all of life's problems, right? You want to put in a balloon pump in the cath lab or even in the ER, sure, no big deal. It helps your EF by about 0.5 liters per minute, right? It's just a little extra boost to augment diastole. It does not help that much. It helps a little bit, right? So when we talk about putting balloon pumps in the ER for people post cardiac arrest, half a liter, a minute, it doesn't help that much, right? That's why we're all pushing more toward VA ECMO in these people.
I mean, what you used to see were people used to be putting balloon pumps during cardiac arrest even, and that was
Yeah,
just,
right.
I mean, just insane, but it was happening. And just because people felt like this was something else. Now, the premise behind this is that you're treating ischemic cardiomyopathy, and you're trying to basically perfuse the coronaries in the setting of someone who's ischemic. But, I mean, eventually, if you've treated the patient, you stented the lesion, do you really need the balloon pump at this point? If you need forward flow, maybe an Impella would be a better option.
Yeah, right.
Or tandem heart. I mean, those are things that you think about, like, what are the
And for all
options
those
that
who
you
don't
have?
know what's an Impella, I mean, when I
Right.
want to summarize what an Impella is, I sort of like say a temporary LVAD.
Right.
Right.
Essentially, yeah.
So I mean, but you're helping with forward flow at that point, because now you're trying to help perfuse a patient because of the fact that their EF is so bad. A balloon pump isn't going to really help so much your perfusion. It helps diastolic perfusion of your coronaries
It's low-hanging
in the
fruit.
setting of
It's
ischemia.
easy to do.
Right.
It's not that big a
People like to
deal.
just add another procedure on the
And it's
plate.
augmenting diastole, period.
Right. That's all you're doing, is you're augmenting your diastolic function, and that's it. And I mean, it's not going to improve your outcomes that much. That being said, you're 100% right. VA ECMO is going to be the way to go. Now the question is, when you put someone on VA ECMO with a horrible EF, where do you go from there?
Yeah, I mean, right. The only thing I could say is that, the heart failure world is exploding.
Yeah.
So you have a million options.
Million
now,
options.
Right.
Right. They'll figure something to do.
Right. So life's a little bit better now, but you have to get to a center that has a mature heart failure program, right? Because most cardiologists are now just not training that much in heart failure. It's a separate fellowship after cardiology.
Yeah.
All right, is there anybody have a quick pre-hospital case, or you want to go right to the articles?
You should just go to the articles.
Okay. Who wants to do the first article?
What did we end on last time? I
Yeah.
remember.
They should be off the list, so any of those articles should
Any
be.
other questions while
No, I just
figuring
didn't know
out?
which one we
Yeah.
did last week when I was flying, so. Like, we can talk about mine, that's fine. So the article that I had this week was about preventable death and interpersonal violence in the United States.
So this is your last time you're doing Journal Club with us,
Yeah.
at least till you come back and visit.
It is.
So Dr. Holbein's finishing fellowship today, going back to sort of take over Chicago.
Yeah, the whole city. So actually, I found this article personally and also professionally very intriguing. Just having done residency in Chicago and me being here in New Jersey where gun violence is a big deal. Can you hear me? You're looking at me like you can't hear me. Okay. Stand by. Can you hear me now?
Thank you.
Excellent. Okay. So this was an article that was put together by the surgery team at University of Colorado. And basically what it was looking at was trying to decide how we need to be approaching preventable deaths in interpersonal violence. And they focused on more penetrating injuries from both firearms and sharp instruments. So they looked at the National Violent Death Reporting System, which is actually a system that all 50 states in the United States and Puerto Rico as well are a part of, where they submit information regarding deaths that could be considered or that are suggestive of homicide, and they submit information regarding these deaths and the method of injury and whether the patient was dead on scene, dead on arrival, meaning to the hospital, or dead at or after the hospital, dead on arrival when the medics got there, or dead or after the hospital admission. And so they retroactively went back and looked at the burns were wounds to the chest or head, and that isolated extremity injuries actually represented a minority of the both firearm deaths and the sharp instrument deaths, which is kind of the whole overall gist of this article is that with the Stop the Bleed campaign and everything that we're pushing out into the public and into the EMS world about the use of tourniquets are really only helpful for extremity injuries, and the reality is that people are in the civilian world are not usually dying from isolated extremity injuries, and so
With the exception maybe of junctional tourniquets.
Right. But even then, if you're going to use a junctional tourniquet, it would indicate that there's that they probably have more than one wound to one extremity, right? Or that it's in an area where the tourniquet isn't going to help you anyways, and so the traditional tourniquet. And so the article kind of looked at the fact that the majority of the way that we approach controlling bleeding and deaths in these situations is related to research that's been done basically in the military setting, where there is actually a higher number of limb injuries that occur, like from IEDs and things like that, rather than head or torso injuries, given the protection that they use. And so we need to think outside of the military realm and start recognizing and focusing on the fact that that preventing these deaths is not only about the medical care that these patients are getting on scene, but also preventing the injuries from happening, because most of the time, by the time the medics get there, these individuals are not resuscitatable, and so we need to talk about prevention. And that's the overall gist of this article, is that we need to consider preventing injury from penetrating gunshot wounds, penetrating stab wounds to the head and torso in the prevention side, just as important, if not more important, than teaching people how to control the bleeding after the injury has already occurred, which I think is pretty poignant. They have, in their discussion here, there was trying to find it. Of course, I highlighted it and it disappeared. There's a section where they talk about, they say that the 20,000 annual homicide deaths in the United States dwarf the estimated 437 people that have been killed in mass shooting events in 2017, and the 700 to 800 annual combat deaths that were happening at the height of the campaigns in Iraq and Afghanistan. So we've had more people die in the United States from homicide from these methods of injury than we have with the mass shootings and the annual deaths that occurred in Iraq and Afghanistan combined. So something has to change, right? This isn't like a PSA for like gun control or whatever, but I mean, the conversation has to be had that this is a public health problem,
Right.
and we have to change something. So,
Much focused more in the United States than other countries.
yes.
Right. And, right, so I think, right, this is something I've learned, that the answer to almost all medical issues is prevention.
Right.
Right, because once you get the disease, it's hard to get rid of it, right?
Yeah.
So it's prevention, prevention, prevention. And this is, prevention, and it's, and Stop the Bleed campaigns are nice, but that's after the fact, right? And, I don't know, I'll just go through a couple of quick things I was thinking as you were talking. One is, you talked about the tourniquets for extremity injuries, right? It's just a pet peeve of mine, if nobody ever puts a big bulky dressing on any wound for the rest of their lives, that will save lives. Big bulky head dressings are absurd. They're the 80s, right? Stop doing it. Although we see this all the time, and we take them off and there's 3 liters of blood. If somebody's bleeding, I want to see them bleeding, right? It makes no sense. And the one thing we learned from the after action report, which Jocelyn did so well in Las Vegas, is it's a myth that you need surgeons, right? Very few people went to, it was like 8 people who went imminently to the OR. A lot of people went in the next 24 hours for orthopedic stuff, but very few people go to the OR who have penetrating trauma to the box, right, to the chest or the abdomen. They all go to either interventional radiology or we observe them, right? So you don't need a lot of surgeons. That makes no sense. You need a lot of ortho guys. You need a lot of radiology techs. You need a lot of people helping you out. But very few people go imminently to open up their belly or their chest. So we know that. And, most of this for simple stuff, these large-scale events, you need tourniquets. But the average guy in the street who's bleeding, you need 1 finger. Right? You don't need a tourniquet. You need 1 finger, 4x4, and you need to put it right on the spot, and it'll stop, maybe a little TXA on top, right? But you don't need a tourniquet on those either. Now, MCIs need a tourniquet because you can't hold direct pressure on everybody.
Right.
But that one patient, just, like one whole, prior to this year, you guys can tell me if I'm wrong, every fellow had somebody die from a fistula that popped and the patient exsanguinated. Every fellow had this in previous years. Why? Because nobody held direct pressure well.
And that's all you really need is that 1 finger on that bleeding.
Especially like a fistula, right? You need to, and maybe it won't work, right? And maybe you need like double tourniquets. Maybe you need some topical TXA. Blah blah blah. But most of the time it just works if the person who's holding the direct pressure is the most important person, right? I don't know. Yeah, so I agree. It's all prevention, but. These are big political issues, and there's
Right.
lots of stuff driving the train here that has nothing to do with medical people.
Right, yeah, the takeaway is that over half of the deaths the 18,000 homicides that they had in this article, over half of their deaths occurred in the pre-hospital setting. Only 13% of those victims were actually admitted to the hospital prior to them passing away. And that's the big thing that we have to start admitting and recognizing, that if you're not right there when it happens, and even if you are, sometimes it doesn't matter. The only way to save somebody's life from these injuries is for the injury itself to not have occurred at all.
Right.
So.
Right. I was just thinking, I remember a conference a couple of years ago given by the Israeli Defense Forces that I lectured at, and then the guys who do it for a living, the IDF guys, got up and they said, "You guys in the United States are so cute." They like pinched their cheeks, and they said, "By the time you're done with your meetings and planning, we'll already have everybody at the hospital." Right? And that's because the community, they get the message that, unfortunately terrorism happens in certain places a lot. So they get the idea, we'll get these guys off the scene because you have very little to offer them for their penetrating or blunt trauma besides CAT scan and imaging, right, which is where everybody's going. But, you don't need like meetings and planning and, all this stuff. You need to get them for trauma, off the scene so we can image them and see what we need to do, right? And most bleeding stops spontaneously, and some people go to IR, and a very, very, very tiny bit of people, no matter what their blood pressure is, need to go right to the operating room. It's almost unheard of nowadays. So, it's just some rules that for some reason we still don't get. Although I think Stop the Bleed is like a nice thing to do, right? Because it tells people like what to do and makes them play with tourniquets and
Yeah, and they even comment on that in this particular article. That's not to say that this article negates or we should do away with that campaign. It has been shown that using tourniquets on extremity injuries, like that campaign advertises and teaches about, does save lives. So it's not that you shouldn't do those things. It's just that if we're looking at the grand scheme of things, is the issue really that we're not getting enough tourniquets out to people, or is the issue that more people are getting shot and stabbed than should be? And I think it's the latter.
Right.
So
It's also a cultural problem, and
Yeah.
Other places they have even more guns and more knives, but they just don't stab or shoot each other. They'd
Right.
rather punch each other and then have a drink afterwards.
Right. Right.
So, if there's any questions, we probably could do one more quick.
Yep.
One more?
I could do the ACS stab to the neck is pretty quick, I think.
Okay.
So it was basically just a case. They used an 18-year-old male was stabbed to zone 2 of the neck. He initially came in with a GCS of 14 and developed some weakness, decreased sensation to the left upper and left lower extremity with tongue deviation to the right. So that's basically consistent with right internal carotid artery injury with the ipsilateral brain ischemia, so not getting enough blood flow to the brain.
Because why? Because the sympathetic chain runs along the carotid artery?
I think they're saying that basically just because when they explored the neck, it was actually at the bifurcation of the carotid, so I think that it just wasn't getting enough blood flow to the brain. The thing they were highlighting in this article was that most people in trauma settings are going to do a head CT at that point to kind of like, I guess, risk stratify because they worry about if this ischemic injury is going to convert to a hemorrhagic injury. But in this case, they took them straight to the OR. They fixed the defect with a...
Because I'm just thinking, when you get a carotid artery dissection, like blunt trauma, you twist your neck, you get a carotid artery dissection.
Right.
They want, they'll get like Horner syndrome, right? And you anticoagulate them by treatment, which is bizarre, but it works.
Right.
But that's how they present, right?
Right, yeah. Yeah, they, the main thing they were saying was just that they shouldn't be doing the head CTs mainly, just be going straight to the OR. But this was like just a case study.
Right. Well, zone 2, I mean, when I trained, zone 2 was you go to the operating room.
Yeah.
We've taken everything away from surgery, right?
Yeah.
I mean, nothing goes right to the operating room. I mean, zone 2, you're stabbed in the neck. And, and then that sort of changed when the CAT scans got better and better. And then we went did esophograms in everybody, and we bronked everybody. We do all this stuff. But now the CAT scans are better and better and better, right? So now we just CAT scan with people, and we do CT plane and CT angio.
Right.
Yeah, sometimes with the CAT scans, especially these people with neck injuries, so zone 2 is like right in the middle, and we worry whether or not it crosses the muscle, whether or not there's air where it's not supposed to be, blood where it's not supposed to be, things like that. It can look seemingly very benign, but they could be bleeding into their chest from there. You just don't know.
Right. So zone 2 is where all the money is. Right?
They used to say, you violate the platysma, you go to the OR.
Yep.
Right.
Now it's like, who cares?
Get the CT.
Right.
There was a lecture that I think Kenji Inaba did on an MRAP piece about evaluating neck injuries, and basically, I think the takeaway for me was like the zones don't matter.
Yeah.
You get a CT angio and you see where it's leaking and take care of it.
Yeah.
So can we take it off the EM board?
No, the
Along with the Ellis criteria.
the
dental
boards are
criteria.
all right. They can't.
That no dentist knows.
Right. No, nothing even kept us up to date. Yeah. So anything? What other thoughts?
No, just the other interesting thing about that was they were talking about controlling the bleeding. They used a Foley, which is interesting.
That's true. Yeah.
Right. So this is why we carry Foley catheters.
If you're wondering why they're in the
In
truck.
fact, what's her name? I still remember.
It's not for police jobs.
God, I'm drawing a blank. Maybe you're out there. She's a first-year medical student at RWJ, and we were there. We were having like dinner. It was myself, a bunch of the trauma guys, and her. She was doing research with us, and we asked a question: why would you use a Foley catheter in the trauma bay, right? And she didn't know anything. She was a first-year medical student, right? And so she guessed, and she was totally right. And I can't remember her name, but I know she's actually an ER attending at Penn now. So why is that? So why would we carry a Foley catheter in our physician vehicles?
It's the tamponade area. So
Right. So like a subclavian injury, right? You have a subclavian injury. You're stamped here. You can't put direct pressure because the clavicle is there. So you got a hole. You float a Foley balloon, and then you compress the clavicle against the subclavian vessel, and you inflate it, and now you can hold that holds direct pressure, right? Worst thing you can do is put a dressing on it.
Yeah.
Never put a dressing on anything that's bleeding.
Especially
because
bulky.
if they
Just a
start bleeding again, I
sponge.
want to know about it. Right.
Yeah. Or you can do a
These
thoracotomy and
always
reach
are
underneath.
Ventricular injuries too, right? Stick it-
Right, it's really interesting. We were at a conference, and I remember what we talked about, and I said, what I learned is that if you have a hole in your, first of all, it's only your right, it's only your RV, right? This is why, like, some people, like in police academies, learn you're going to stab somebody, you stab them like on the side here, right? Because then they get their LV, and you can't save them no matter what. You stab them up here, you get the right side of the heart, and then you potentially can open up their chest quickly and save them, right? So we all know that. So you open up their chest, and now we all learn that if you put a Foley catheter in the hole, then you can actually stop them from bleeding. And when I suggested this, all these guys who trained at multiple institutions in surgery said, that's crazy, that's totally wrong. And I'm like, but it's in all the books. And they said that you have endocardial ischemia, when you do that, so it's all stapling. It's all stapling the myocardium, which we do too, but you don't put a Foley balloon in, despite that's what all the books say. I thought it was very interesting. So you need your staple gun. So, okay, what else? What else, Dan?
That was pretty much it from that article.
So, and then you can get some TXA.
Yeah, TXA, and then they have all those like the new stuff that we were talking about before, like that extend, like not extend, but
The
absorbable, like the balloons and stuff.
Yeah.
Don't put bilateral carotid pressure. These are things that we say now, but in the heat of the moment, you might actually try it because it makes sense that.
So we always talk about that. I mean,
bleeding.
if you're bleeding by your carotid, you do put direct pressure, right? Right. Blood gets to the brain in 4 ways, right? You learn this like in college, right? You have vertebrals and carotids, right? So if you're bleeding from your carotid, put pressure on it. It's okay. Put pressure on it, right? You still got your vertebrals and your other carotid. And what happens when something happens to the carotid? We'll oftentimes just ligate it in the OR, and it doesn't really matter to us, right? If you're young and healthy, et cetera, et cetera. So, anything else? Any other questions coming in from us? All right, we're gonna end early. It's 3 minutes to 2 o'clock. Thanks for tuning in. We will be back next Wednesday. Is that right? Oh, we are not here next Wednesday, so if anybody's around New York City, I'm giving grand rounds at Mount Sinai next Wednesday on everything emergency medicine and EMS at some time in the morning on the main campus at 9 a.m. And most likely I'll be there if somebody reminds me. And but anybody's welcome to come to Mount Sinai next Wednesday. All right, everybody, thanks for tuning in, and we will see you next week.